Hello, this is Oleg, Borisenko and Market Access Insider channel. In our programs we discuss organization and financing of healthcare services and medical technologies in European countries. Today we're in Berlin, Germany, and we're going to talk to Dr. Wilm Quentin from Institute of Technology and Management in Berlin. He's one of the best experts in German and European healthcare systems. We're going to cover a broad range of topics, including organization and financing of hospital and ambulatory services, statutory and private health insurance, the DRG system and EBM catalog, and the future of GBA Innovation Fund. Hope you will enjoy the program. Can we now move to ambulatory sector? Could you describe the payment system there?
In the ambulatory sector, there are two different payment systems for sickness funds and for the private health insurance. Mm-hmm. The one is the EBM, the Einheitlicher Bewertungsmaßstab. It's basically the fee-for-service schedule for sickness fund patients. On the other hand, there's the GOR, which is the Gebührenordnung für Ärzte, the fee schedule for physicians, which has a different logic. And the most important difference between the two is that in the EBM, many services are bundled together in larger bundles. So basically there's a basic consultation fee that covers most of the costs of patient care during 3 months of treatment always. So it's kind of a contact capitation, which is part of the EBM, and then there are additional fees that physicians can charge if they do additional services for their patients within these 3 months. Mm-hmm. Whereas the GOR, the fee schedule for private health insurers, it's much more individual fees for every individual service provided by the physicians. And generally, it's more profitable for physicians to provide fee-for-service paid service according to the private health insurance system also, because they can usually charge multiples of the basic consultation fee of the private fee schedule, like they say times 1.7 times 3.4 to increase their revenue per point. And the point value in the sickness fund part of the payment system, it really depends also on the volume of services that is being provided, because in fact the negotiations between sickness funds and physicians, they start not at the level of the value per service, but they start at about the overall budget that is allocated to sickness fund physicians. So they negotiate about how much should the general budget for the basic services increase. Mm-hmm. And then from that, they will start calculating the point value that each individual service has. Mm-hmm. But because there's often a difference between the number of services that were provided in the previous year and the number of services that will be provided in this year, there's also a budgeting system which kind of limits per individual practice the amount, the volume that the physicians are allowed to provide, which is called the Regelleistungsvolumen, so the norm volume of services being provided at the level of individual practices, and if this is exceeded, then the reimbursement is reduced per point of service being provided in ambulatory care.
All right. And is the cost of expensive materials covered within EBM fee, or is it paid extra?
It depends. Expensive materials are usually not covered. Mm-hmm. So expensive materials are often charged extra. Like for example, if you do a cataract surgery in ambulatory care, then there will be there will be an extra fee for the materials, for the lens that you implant into the eye, and for the surgery, and for the fee for anesthetics, and for the first visit, for the checkup of the patient. These are all individual fees that, in order to calculate the total cost of, for example, cataract surgery, you would have to aggregate those fees together in order to know mm-hmm. what the cost would be. Yeah. Mm-hmm. But often, and there can, like for example, for ambulatory surgery, there's often also state-level negotiations between sickness funds and physicians about the reimbursement of these technologies and about the reimbursement of these fees. And the fee schedule then may in fact look differently at the regional level from the general federal framework. And there can be also selective contracts between individual sickness funds and individual practices about how much they would reimburse for the performance of an ambulatory procedure.
Mm-hmm. So it is known that it's relatively difficult to introduce a new EBM code in the German system. Could you elaborate on the process? So who initiates it, and then what's the whole process, how it looks like?
Yeah, the difficulties with the introduction of new EBM codes is really that it depends on the self-regulation of the physicians and the sickness funds. So while we have the Institute for the Hospital Payment System, which operates relatively independently and then proposes a new catalog, and basically the self-regulatory partners only need to say yes or no. It's much more complicated for ambulatory care because there they manage this system themselves, and because they obviously have different interests in either reducing the budget or introducing new technologies and increasing the revenue for the physicians. Mm-hmm. It's much more difficult. There's a valuation committee within the Federal Joint Committee, and that is the institution that is responsible for introducing new EBM codes. And this valuation committee has their own institute also, the Institute of the Valuation Committee, that provides advice, and they may do analysis of the costs of new procedures or of existing procedures also. But in general, the revisions of the fee schedule in ambulatory care take place much more irregularly. So there's no regular system of changing the relativities between the fee values. The relativities remain relatively stable, and only if everybody agrees that, for example, ambulatory MRT scans are overpriced, then there can be a system of reducing the relative value of an MRT scan in ambulatory care. But it's much more irregular and much more difficult to achieve the reduction because they have to agree, the opposing parties within the EBM, the valuation committee, and only if they don't find an agreement, then the valuation committee is expanded. It becomes the expanded valuation committee, where they have one more representative, which is supposed to be a neutral representative, and so then they don't have equal voting powers, but there's one more, and so that may then tip the decision to one side or the other side.
All right. And who usually initiates the process of creation of EBM code? The process of
it often comes from the physicians, in fact, who make the proposal, but the physicians, they are not really, often they are supported then by also manufacturers of technologies, because they are the ones who are being contacted by producers or manufacturers for having a new technology, and then they may adopt this proposal and make the proposal within the Federal Joint Committee.
Mm-hmm. But it's also, again, only the association could propose, right? So it's not just the individual.
No, it's not individual physicians, it's the association that is represented in the Valuation Committee, yeah.
So the different payment systems in Germany, like in hospital and ambulatory sector, creates this silo budgeting mentality and potentially a barrier for many technologies that are on the borderline. So are there any initiatives to kind of combat this silo budgeting, and in general, are there any potential new regulations in the field of financing?
Yeah, it has been an important topic for many years. And I've worked on the topic of the silo, the sectoral boundaries between inpatient care and outpatient care, and the silos of budgets a few years. And sometimes if you read reports from the early 2000s, they always say there's this problem of silo mentality and it needs to be overcome. But if you read reports from last year or 2 years ago, it's often the complaints are the same. Mm-hmm. And basically what has happened in order to, there has been one of the biggest problems of the German healthcare system is the large inpatient sector, and so there has been the attempt to move things to ambulatory care. But because hospitals kind of fear that they will lose their market of inpatient treatment, and the ambulatory physicians say, if we are supposed to take on more patients, then we need to receive more money. There has been really, the process has been more or less blocked. And what the regulator, the parliament has done in new laws that were introduced, always introduced possibilities for hospitals to become active in certain small areas. And so there are many different reimbursement systems for outpatient care provided by hospitals. but there's no general systematic approach for reimbursement of outpatient care provided by hospitals. So they're different for psychiatric services provided by hospitals. It's reimbursed differently from outpatient care provided by teaching ambulances of hospitals, which is again different from ambulatory surgery performed by hospitals. And there's no uniform system. And one of the objectives of the current federal government, which was specified in the coalition agreement, is also to establish a commission, a federal state level commission, a joint commission to think about the regulation of this at the border between ambulatory, at the sector between the border between inpatient care and ambulatory care.
Mm-hmm.
Another commission that is currently, or into reform that is currently ongoing, has been an expert commission that has been established, that has been called to make proposals for reforming the ambulatory fee schedule and potentially to harmonize the fee schedules for statutory patients, sickness funds, and for private health insurance.
Mm-hmm. Are there any changes expected with the DRG system, or is it going to be more or less stable?
Oh, there are always changes planned for the DRG system. With the previous government, there were a few changes that were introduced in the DRG system. One was to kind of reduce the incentives for over-provision of certain services. So now there's the possibility, if the INEC suspects that certain services are provided because of a financial incentive, then it's possible to reduce the relative value of that particular service. Mm-hmm. There were also reforms to introduce add-on payments to assure the availability of services in hospitals in rural areas. So there's a surcharge for hospitals in rural areas because they may not have the volume to sustain the financial viability of the hospitals. Mm-hmm. And there was also the process to develop add-on payments for centers, for centers of expertise, but there it was difficult to define exactly what a center of expertise really is, and so it was that there were long negotiations again in the Federal Joint Committee about how to define a center of expertise. And then another area of payment reform was also to change the reimbursement for emergency care provided by hospitals, and so hospitals were classified into different clusters of emergency care provision: basic emergency care provision, like more advanced emergency care provision, and very high-level emergency care provision. And depending on the cluster into which they were classified, they now receive a different general budget that covers the existence of these structures for emergency care provision. And in the current coalition agreement, they decided the German hospital sector is very large. There are many hospitals, many beds, but the staffing in hospitals, although it is quite generous, in relation to the number of beds, it's not so generous. So basically, the number of nurses per bed in German hospitals is relatively low in international comparison, mostly because the number of beds is so high. And so in the coalition, so there are concerns that the number of nurses per bed is too low, and so in the coalition agreement they said that they would exclude the nursing costs from the DRG system. Mm-hmm. But it's not really decided yet how this is going to happen, because of course it's difficult to simply reimburse the same nursing costs for everybody, or for every department in a hospital, and you need to have a measure of the nursing intensity of care provided, and therefore you would again need something like a DRG for nursing care in order to be able to know how much nursing services you should provide per patient in different departments. And it cannot be that basically all nursing costs will automatically be reimbursed by the statutory sickness fund.
All right. So you mentioned previously selective contracting. So could you explain the difference versus collective contracting, and then so what's the idea behind, and then in which situations is it commonly used?
Well, the idea of selective contracting is that to increase competition in the healthcare system, and to provide more incentives for, or to enable sickness funds to develop a competitive advantage towards other sickness funds. And the idea would be that they make a selective contract with certain physicians that are where they can say we assure the quality of these services, and we can tell our patients that these are really the best physicians for their conditions, and then they can make a contract with the physicians and say we will assure that you will get many patients from our sickness funds, from our sickness fund, and that will then kind of distinguish this sickness fund from other sickness funds. But I would say in general, or for a long time, this selective contracting has developed relatively slowly because sickness funds already pay for the collective contract, and so they have relatively limited interest to pay extra for the selectively contracted services without being able to remove those selectively contracted services from the general collective contract. And so there have been long discussions about how to kind of subtract the volume of services selectively contract from the general contract.
All right.
And one area where this is relevant also is for the introduction of new technologies. For example, for cataract surgery, if like a sickness fund would say, we have made a contract for new lenses from this company, then we have negotiated a good rate, and so we will give you this lens already, and then you implant it, and that may lead to a lower price, maybe because now contracting and collective purchasing for all the patients of the sickness fund, the lens may lead to a lower price.
Does it mean that typically that would be the scenario for technologies or procedures that are not yet well covered with collective contracting, right? That it's something...
That's one of the more frequent areas where selective contracts happen, yeah.
And could selective contracts cover both inpatient and ambulatory care, or only ambulatory care typically?
No, they can cover both. They cover both inpatient care and ambulatory care. For inpatient care, there can also be some kind of quality contract to say that we cover maybe the costs of inpatient care and rehabilitation together if there is like a hospital chain that offers both, and then they can say we do kind of a bundled payment for inpatient care and rehabilitation, and if you provide us the quality indicators that it is good care, you will get an additional add-on payment for this bundle of services being provided. So, and it's relatively free and liberal how these selective contracts are specified. For inpatient care and for ambulatory care.
All right. So another initiative to booster the research, it was the Innovation Fund at GBA.
Yeah.
Right. And then, so could you elaborate on the idea behind this fund and the current status? And also we know that its mandate is up until the end of 2019. Are there any news about, is it going to be prolonged?
Yeah. First, the Innovation Fund was really a big initiative for the German healthcare system and also for researchers in the German healthcare system, because basically it provides, on the one hand, funding for health services research, and a lot of new health services research projects have been introduced, and on the other hand, it provides funding for new healthcare provision models, and often these healthcare provision models concern like also how to improve collaboration between inpatient and outpatient care, how to improve care for like artificially ventilated patients, how to introduce new technologies, how to link rural areas to centers of expertise for cardiology. So there are many examples of different interesting healthcare provision models, and these then always need to be introduced together with the systematic evaluation of the new technology. And so that has led to a lot of new technologies, research about new technologies and provision models in the German healthcare system. However, most of the projects are just finishing because the Innovation Fund started 4 years ago, and most of the projects were 3-year projects. So basically, the results of the first projects are just starting to come out. And in the new coalition government, in the new coalition agreement of the current government, they agreed that they would continue the Innovation Fund with 200 million euros. So there will be again more research, more and more innovation projects. but I haven't really heard about like more specific decisions about how to continue the innovation fund.
Mm-hmm. But most likely there would be extra funding, right?
Most likely there will be extra funding, yeah.
Mm-hmm. All right. And probably the last question. So if we look at Germany from the organizational financing perspective and healthcare system, so how is it comparable with other European countries? Again, in terms of efficiency, in terms of value for money?
I think it depends a lot on who you ask. I would say in terms of efficiency, if you simply take, and of course it always depends on what do you take as the output or the outcome of the healthcare system. The German healthcare system is relatively efficient at producing services. So basically hospital services are not particularly expensive in Germany. They are relatively mid-range, and the German healthcare system produces a lot of services. So in terms of technical efficiency, the German healthcare system is relatively efficient. In terms of allocative efficiency, the German healthcare system is probably not so efficient because it just allocates too many resources to treating patients in the inpatient sector, whereas it could use more resources in the ambulatory sector.
All right. Excellent. Dr. Quentin, thank you very much for your contribution. That was a very insightful interview.
Okay, thank you.
Thank you.